زوم زوم ولا ايه؟ بسم الله الرحمن الرحيم. دلوقتي اقدم بروفيسور روبرت جورج من انجلاند يكلمنا عن surgery in lung cancer treatment, present status and future perspectives. المحاضرة زوم.
Good afternoon, chairpersons, ladies and gentlemen. First of all, I would like to thank the committee for inviting me to this prestigious congress run by the Egyptian Society for Chest Disease and Tuberculosis. I would have loved to be attending this meeting in person, but due to unforeseen circumstances, I'm recording this lecture. The title of the talk is Surgery for Non-Small Cell Lung Cancer, a Current Practice and Future Directions. I have no financial interests or relationships to disclose. As you're all aware, lung cancer is a leading cause of cancer-related deaths in the world, affecting 2 million new patients each year and is associated with 1.75 million deaths per year. Most lung cancers, approximately 70%, are diagnosed in advanced stage, but recently non-small lung cancer is being detected in high-risk populations, mainly because of screening or CT scans for patients followed up for other cancers, for thoracic symptoms, or more recent for COVID-19 symptoms. The National Lung Study Trial and the Dutch and Belgium lung cancer screening randomized trials have shown reduction in lung cancer mortality rate by 20 to 24% respectively. If we look at the MENA region, you can see that Egypt has approximately 130,000 recorded new cancers, and 5% of those are new lung cancers. I find these figures a bit too low. However, this is WHO figures that have been published regarding lung cancer, specifically in Egypt in 2020, showing 1% of total death happening from lung cancer. This is much lower than figures in the UK, USA, other countries in the MENA region, such as Tunisia, Lebanon, and Jordan. Again, I find the mortality figure related to lung cancer is too low in Egypt. Maybe this is to lack of screening, or rather lack, but absence of screening, I would say, and perhaps lesser diagnosis. Complete surgical resection of non-small cell lung cancer continues to offer the best chance for cure or local and regional disease control. The principles of surgery in lung cancer are four main folds. Firstly, to perform a safe and effective operation, achieve complete resection with a zero margin and adequate clearance of lymph nodes. We use a patient-centered approach, and over the past few years, the introduction of the early recovery program. The preoperative assessment relies on imaging, pulmonary function testing, and calculating the predicted postoperative values. Tissue biopsies uses CT-guided biopsy or surgical approach, assessment of cardiovascular status and other comorbidities that may represent any contraindications to surgical intervention. This is a busy slide, but on the left over here, we look for lung cancer resectability based on FEV1, and if it's more than 1.5 liters, that patient is the lung cancer is resectable and the patient is operable using a lobectomy. To perform pneumonectomy, we need FEV1 of 2 liters and above. If these figures are not at the levels that are required, we perform a transfer factor or TLCO, and we look at if it's less than or more than 40% of the predicted values. If patients have lower values than FEV1 and TLCO of less than 40%, we consider this high risk, but also put them through exercise testing by shuttle walk tests or even undergoing MVO2 or exercise testing. The other component of assessment is we look at the cardiovascular background, and if they have any comorbidities, we look at consultation with non-invasive cardiac testing and treatments on AHA and ACC guidelines. If patients need CABG or PCI, we perform that before undergoing surgery, or and continue cardiac care to prepare the patients for thoracic surgical intervention. We all know the 8th edition of TNM classification based on tumor size and structural involvement, lymph node involvement, local and distant metastasis. So T1A depends if it's minimal invasive, and that's T1A. T1A also represents of any tumors that 1 centimeter or less in the greatest diameter. 1B, 1 centimeter, but not more than 2 centimeter. 1C is tumor that's more than 2 centimeters, but not more than 3 centimeters. T2 are tumors, tumors that have between 3 and 5 centimeters, but involving main bronchus, invading visceral pleura, associated with lactases, obstructive pneumonitis, and extends to the hilar region. Looking at the regional lymph nodes involvement, we look whether lymph nodes are involved or at what stage they're involved, whether N1, N2, or N3. And we do this either by, as we said, pulmonary PET scanning or EBUS, or of course, mediastinoscopy. The nodes that are accessible most by mediastinoscopy are 4R and 10, 7, and sometimes we can get 4L, but we have to be very careful when we approach the 4L region. Distant metastasis is the third component of TNM classification, and it looks as M1A, 1B, and M1C. And you're aware that 8th edition of TNM classification has introduced the M1C, which involves multiple extrathoracic metastases in one or several organs. The most favorable surgical candidates will be those lying into N0, N1 nodes with stage between 1A and 3A. And of course, there is a lot of controversy whether to operate on patients who are involved with N2 disease. We tend to operate, or I tend to operate on patients who have a single station N2 disease. Surgical techniques, whether we undergo resection by lobectomy, pneumonectomy, or we do also limited resection by wedge excision and segmentectomy. This is a schematic diagram showing a wedge excision, which is preserved for patients stage 1A tumor and or have a small peripheral adenocarcinoma with a ground glass opacity appearance on high resolution CT scan. Segmental resection is anatomical segmental resection, where we go deeper into the anatomical segments of the pulmonary artery and the bronchus and the veins, and dissect those segments separately. And of course, lobectomy, where we undergo a full lobe excision. The very first randomized controlled trial by Ginsberg in 1995, which is now 27 years old, looked at 247 patients with stage 1A lung cancer, and they find there was decreased survival by undergoing sublobar resection versus lobar resection, and also increased recurrence rates by 75% in patients undergoing sublobar resection. Although these increased changes were not significant, yet there was a lot of development that happened over the past 20 years to be able to achieve a higher levels of success in sublobar resections. Recently, Al-Turki from New York in 2018 have published another randomized controlled trial looking at 697 patients. 357 of those underwent a complete lobe resection compared to 340 who underwent sublobar resection. The outcome of 30-day and 90-day mortality were similar with no significance, and suggesting that major of operation performed with a minimal invasive surgery, and all patients had performance status 1 or ECOG of 1. Other studies have also shown survival. There was post-operative length of stay benefit in patients undergoing sublobar resections versus lobar resections. There's a recent study from the National Lung Screening Trial looking at 53,000 patients from 33 USA centers, and 1,029 underwent surgery. There was again a similar outcome on 90-day mortality, major pulmonary comorbidity, 5-year cancer, specific survival data comparing to lobectomy versus sublobar resections. For stage 2 lung cancer, patients benefit from surgical resection, and it's advised to undergo lobectomy for these patients. The most important component now in lung surgery is the introduction of the enhanced recovery program, which involves 3 phases. The first phase is preoperative phase, patient and family education, optimization, prehabilitation of selected patients. Second phase, intraoperative phase, which uses multimodal analgesia, intentional fluid administration, normothermia, normoglycemia, and the post-operative phase, which is early nutrition, early mobilization, and also multimodal analgesia. And early recovery program has shown improved post-operative outcome, including pain control, decreased length of stay, decreased pulmonary and cardiac morbidity, and facilitated the delivery of adjuvant chemotherapy in patients requiring chemotherapy. The surgical approaches we use are posterolateral thoracotomy, but this has been recently changed to VATS lobectomy. We still proceed with open thoracotomy in certain cases, but most cases undergo VATS lobectomy. VATS lobectomy has evolved from a 3-port VATS where we stand behind the patient and we use an instrument port, camera port, and a utility port. And also that has changed from a posterior approach then to anterior approach. And then we have changed this to 2-port VATS where we have eliminated the posterior approach. We use the drain port as a camera port and an anterior port only. And there was a learning curve to look at lobectomy, and we have found the conversion rate is less than 5% now. Then further development and evolvement of the VATS technique has gone from 3-port VATS to 2-port VATS to uniportal VATS. And this is a uniportal VATS view where all instruments and the camera are inserted from a single port. Let me just show you a quick video of a left upper lobectomy. This uniportal VATS where I'm dissecting outside in front of the mediastinum anteriorly. I'm just opening the sheath in front of the pulmonary vein, superior pulmonary vein. Let me just fast forward that. You can see over here, this is the pulmonary vein, and I'm dissecting around the sheath of pulmonary vein. This is the phrenic nerve. I'm dissecting station 5 over here. And then again, I'm opening the sheath in front of the pulmonary vein, finding the gap between the pulmonary vein and the pulmonary artery at the background. Now I'm going very gently through the gap between the 2 vessels, opening a space between the pulmonary vein and pulmonary artery, where I generate enough space to pass a stable across. Now, after that, I carry on dissecting the lymph nodes. Station 7. Station 10, sorry. And I'm going through the superior pulmonary trunk now. And this is a view of the pulmonary arteries, which will be dissected, followed by the bronchus and a complete excision of the left upper lobe. Now, comparison between uniportal VATS and multiportal VATS have confirmed that there's favorable outcomes of uniportal VATS lobectomy in treatment of lung cancer compared to conventional multiportal VATS. And we've looked at the post-operative length of stay, ICD length of stay, and overall mortality. And you can see there is a difference, although it's small, but it was significant. Instrumentation, we use standard surgical kits with the multiport VATS, but with uniportal VATS, we use dedicated instruments where the opening is thinner to allow the instruments passing through one opening, or rather one port. We also use high energy devices such as the Covidian or the Harmonic. And I also use the non-rib spreading soft tissue extractor. I usually use Alexis, but of course we can use anything in the market. Lately, we have been also using robotic surgery in the UK. I'm here at the console. We operate on patients with a female patient with a thymoma. I have the team over here lying the ports and lying the robotic arms to allow for the procedure. So in summary, lung cancer is a leading cause of cancer-related deaths in the world. It's a stepwise approach to investigate and assess the patient. We need a multidisciplinary approach to assess the patient and to select our surgical patients. Staging must be accurate, so is planning. A minimal invasive approach has been beneficial, with reduced complications, post-operative length stay, duration of intercostal drains. VATS has become a standard technique in all stages from stage 1 to stage 3A cancer. I only refer to open thoracotomy when I have bulky station 7 or chest wall involvement of the tumor. Of course, new centers are starting VATS program. There's a learning curve that we must follow. Thank you very much.